Come to Jesus, so we chatting, doing chatting there. I'm hope. Well, I shouldn't say we'll make meeting change.
I know.
I think the only thing.
Yes. Well, it's just like
Who is that?
It's like,
He's like, just smile and wave.
Quiet for him.
we like when you run into somebody like you think you know.
yeah. So yeah, but me too. So how do I search for it on the portal?
Did you both at the same time?
I put in daycare and I put in childcare, and then it's the city of West Valley. Maybe it's neighborhood bigger. I thought of calling some of the
So we're
schools
back
that
2 months later.
because I'm sure they
I
probably
like
have
your. I like the.
like a bus or something.
Yeah,
a
the
bus
location
somewhere.
of the thing, yeah, there may not be any in West Valley.
Yeah, that might be.
Years from now, just so I can see what your reaction
Well,
is
you'll
going
remember
to
this
be.
conversation and say, hey, Eric, I remember you.
I have this little box.
I was,
Are you?
my boss and I went to
Baby, and she's all of our school that she knows.
my university.
Oh, mine was so bad. Yeah, my husband had to take me back to Saturday morning.
Guys sitting at the table.
We sat in the parking lot. I had to like totally build myself up.
I'll make
It
sure
was
that she's
so
on the list for it.
so painful. Yeah, he couldn't get it through.
He was out of context.
No, I
He was out of context. I could not figure out how I knew my brother. Oh my God.
It makes me worried, like if I ran into him at the grocery store.
It's like, it's just everything's so intentional. For me,
Yeah, and
I mean, I'll be honest with you. If I ran into you somewhere, like, I know you. If I ran into you here, if I ran into you over the center, I mean,
Yeah, they just
no.
it was not bad at all. Oh, that's good. I'll check to make sure because I wondered about rest. Good.
yeah, yeah.
They're so nice.
Honestly, don't have to consider the Imatrix and everything they put me on.
Oh,
I
no,
can't
cold.
find it, right? You know, you're just like,
I was
so, yes, so I'll take this over medication.
That means you need to put more money into it.
It's just you have a good plan.
Well, yeah, I put more money into it. So guess what I did last night? A tenor saxophone. I haven't played in 30 years. Well, get this. My friend from high school started bugging my wife and saying, "You ought to get Eric." Well, I was going to. She kept ringing me. Creative outlet. I think it's really good for you to go do it. So I investigated 2 days, and then I stopped by on Monday night and Sundays. Really a pretty good deal for the next horn, but it just needed to come to their shop. So they ran it for the shop yesterday, and I stopped back in and
I think that was one time I knew you were there.
I kind of want to high five you.
I was just going to say that. I used to be good. I kind of am not so good anymore, but
Okay, I think we'll get started in about 30 seconds.
oh, did you? What trombone are you in?
We're set. Let's start.
There's no way that I'm going to go out and play the trombone.
For sure you'll remember. All right, I guess I'm going to start. Good morning. I'm Mindy Keeler, and I'm happy to see you guys here this morning. I hope your ride in was uneventful, and we'll go ahead and get started, even though we know that there's probably a few people coming in. Sorry, Mike.
Did any of you park on the south side of the building? There's this Dodge Durango, Nissan Versa, Subaru Forester, and a Mini Cooper.
Are they all in the process of being towed?
No, we're just repaving out here, and so the equipment's coming in, and we just want to make sure
You
this
don't want to pave your car into the lot.
everybody's good.
Okay, so we'll, if any stragglers come in, we'll
Yeah,
let
they've
them
got it
know.
blocked off now,
Okay.
so it should be good, but we just need to get this.
Okay. All right, so let's go ahead and get started. And no worries if people are continuing to come in. That's just fine. We'll embarrass them. So let's go to our agenda. Here's what we're looking at today. I think most of you probably have seen this in our emails. We're going to have a bit of information, updated information on the Primary Children's Connector Program. and then we'll have a panel about essentially therapy and what it can do for children with special health care needs. So, is it Sam?
Yes.
Sam, I think I'm not sure where that name tag went, but I was
Right here. Teresa,
great,
she just
great,
came to
okay.
sit by me.
All is well. Okay. So with that, we always like to do introductions. So we're going to take a couple of minutes and go around the room. I think because I have a tendency to forget what I can't see, that we'll start with our go-to-meeting folks. But I'll go ahead and fully introduce myself, and then we'll ask if they're able to unmute and introduce themselves, or they can chat, and Gabby will that information. But my name is Mindy Tueller, and I facilitate this meeting, and I manage the Medical Home Portal, which is, I hope all of you know, an online resource that's intended to help those who care for children with special health. So we'll be looking at that this morning as well. So, Gabby, I don't know if you'd like to introduce yourself, and then we'll do the
So my name is Gabby Paragoshi. I'm one of the QI coaches at UPIC and also helping Mindy with the Medical Home Portal. And we have several people online, and I think all of them except Dawn are muted. So let's start with Dawn. Can you introduce yourself, please?
Hi, I'm Dawn. I'm the other QI coach with Bentley's not.
All right.
Hi, Dawn.
Then we have Carl on the phone. Carl is he is muted, but I know who he is. He's a care manager at Kiva Valley Pediatrics. Hi, Carl. Then we have Katie on the phone. Katie's a care manager at Intermountain. I forgot which practice she is. Maybe you can type it in the chat. Oh, Katie. Kearns Clinic. Kearns Clinic, perfect. Then we have Melinda Dibbles on the phone, online. She is a care coordinator at UVP. And then Natalie Allen is...
Our nurse practitioner, yes, with Integrated Services.
Hi, Natalie. Oh, and then Cecily Tillman, I hope I pronounced your name correctly. Can you introduce yourself, please? She is unmuted, so she should be able to. Nurse care manager at Memorial Pediatrics. Thanks so much. And that is everybody online for right now.
All right, very good. Okay, so we'll go this direction. Corinne, if you don't mind.
I'll turn around because most people are behind me. I'm Corinne Romero. I'm the nurse care manager at the Service at Primary Children's.
And I'm Sam. I'm the transitionist with the Connector Service at the Primary Children's.
I'm Michelle. I'm an OT for Primary Children.
Thank you.
Carly?
Carly, I'm the care guide at Southwest Pediatrics.
I'm Kim. I'm the care coordinator at Southwest Children's Clinic.
I'm Teresa. I am the director of rehab at Shriners Hospital.
I'm Neva, physician liaison at Shriners Hospital.
Walt Torres, Integrated Services, Department of Health.
Harry Martinez, care coordinator with Integrated Services, Department of Health.
Hi, Eric Christensen. I'm the program manager for Integrated Services with Utah Department of Health.
Greg Hawks with James Mason Centers for Teens. I do marketing and community outreach.
Jeanette Tingy, I'm care coordinator for Utah Valley Pediatrics Plaza Office.
Mindy Butters, care coordinator at Utah Valley Pediatrics Provo North Office.
Tara, medical home, Wasatch Pediatrics, Cottonwood.
Susie, I'm a care coordinator for University Health Plans.
I'm Heidi, I'm the pediatric nurse care manager for University of Utah Redwood Clinic.
Gina Money from Utah Parent Center and Utah Family Voices.
Kay Haynes with resources on the medical home portal.
Iverson with Help Me Grow Utah.
Heather Adams with Utah Eddie and Utah Family Voices and Utah Parent Center.
Cassie, I'm a care coordinator at Wasatch Pediatrics South Point.
Heather Castor, Med Home for Wasatch Pediatrics Draper.
Linnea Bauer, I am the services support manager for the medical home portal.
Had a couple more people come in, but we'll let you skate by this time. All right, just a little bit of housekeeping. So the bathrooms are a little hard to find, but if you... Sorry, Wes. Oh, I do it every time. Wes, please introduce yourself.
Hi, Wesley Smith, Tri-County Health Department. I'm the care coordinator for children with special health care needs.
Wonderful. Wes is in our Vernal site. We're so happy you could join us this morning again. Okay, so for everyone, the GoToMeeting folks and Wes, bathrooms in this building are located down the hall, and if you came in on the east side, you're going the right direction. If you head back there and then just kind of take a kitty corner right by the, I guess, the vending machines. And that's where the bathrooms are. If you need Wi-Fi, it's the Blue Zone network. We'll do that. And then we actually get cut off promptly at 10 a.m., so we need to be sure and wrap things up by 9:59 to avoid that awkward thing that happens, and we don't want that. So we'll be watching the clock. Happened before. So I have a couple of announcements. I wanted to let you know that essentially starting right after this meeting, the emails that we send to you look a little different and look a lot better. So we have gotten a subscription to Constant Contact, and I don't know if you get any other emails through Constant Contact, but they're very pretty. And what it also allows us to do is have a much better idea of who's opening things, if they're clicking on things, that sort of deal, so that we can continue to improve how we send you information. So we're going to give that a try, and we love your feedback on that. But when you see the resources of the month for this month, it's going to look quite a bit different. Don't be alarmed. That's intentional. All right, and then I sent out an email, I don't know, a couple of weeks ago now about this care coordinator training that Ouch is putting on. It's actually tomorrow and the next day, and I think it's all day. I would have loved to have done this. Unfortunately, my schedule wouldn't permit it, but I hope that there might be somebody in our group who has registered and is planning to attend. And if you do, we would love to hear about it. So not necessarily putting you on the spot, but if you'd like to maybe follow up afterward with a quick, summary of what you thought, I would love to know more about how this training went. So please keep that in mind. And if you are interested, I have no idea if the registration is closed at this point, but let me know and I can send you that information again if you'd like it. All right. So with that, we'll go ahead and get into our brainstorming time. So this is your time. This is the time when we want to let you have the floor for a little bit. You're amongst your peers who might be able to do a little crowdsourcing. If you've got any cases that are you're kind of having problems finding resources, knowing what to do next for the families that you serve. This is also an opportunity to talk about any new resources that you've become aware of, any updates on prior cases that have gone well or maybe not so well. We like to know how things are going with those that we've heard before. We love to also hear about CY wins and interviewing opportunities that you've taken. So really anything. This is an opportunity for us to share as a group what's been going on. See if we can learn from one another and also maybe help one another. So, is there anyone who'd like to start us off with a case?
Wes, be on standby for this one. I just kind of wanted to talk about or ask the general question, what do folks do in cases where you have a household with, I shouldn't say a household, we have two households, so mom's in one, dad's in the other, child is joint custody, may not be joint custody, maybe you have legal involved, maybe you have, some issues there. How do you go about ensuring that appropriate parties are notified if you're doing testing or you're doing any sort of evaluation for those kids to make sure that both parents are notified if both parents need to be notified or only the custodial parent is notified if that's the case? We had a kind of an interesting one, our very first clinic in Vernal. So right out of the chute, right from the frying pan into the fire with kind of a touchy situation. And I felt like Wes was really great kind of figuring that out. So Wes, will you elaborate just a little bit on kind of what our situation was and the great lengths to which you went to figure that out? And then maybe if folks have some suggestions for us how to think about that in the future.
Thanks, Eric. So yeah, we had a kiddo who was nonverbal, about 2 years old. Had her in for developmental peds and psychology, and dad and paternal sister really pushed for the clinic. But then at the last minute, dad kind of was like, hey, I just started a new job. Can I send my sister? And so I staffed that with the team. And he said, oh, yeah, the sister knows kiddo just as well as I do. And when we got into the psychological interview, we were missing a lot of questions the sister just couldn't answer. And so we kind of had to reroute and get dad back at the table. And then, you know, I kind of got some feedback from some community partners. Hey, where's mom in this? And dad was not real forthcoming on how to get a hold of mom. In fact, he told me I needed to go through DCFS. And so luckily I have some friends from the work that I've done with DCFS, and I went in there and very delicately, without revealing any personal health care information, I said, hey, I've got this case. Here's the situation. You guys have worked with this kid. Is there any way you can get mom my card? And so the CPS worker said, yes, I know who you're talking about. I'll get the card to her. And so I kind of had to go at it kind of sideways, but we ended up getting mom there, and I think that was a very important part of the puzzle. So that's something that I'm definitely going to be careful not to overlook in the future. But it was sort of a tricky dance, you know, not to reveal any information about this kiddo and you know, respect the privacy rights. But we ended up making it happen. Dad was kind of a challenge to get in, and I was starting to get a little discouraged with him because it sort of appeared that they were less interested in getting a kiddo help than they were building a legal case for custody. So it kind of got a little sticky.
Thanks.
Anyone had a similar situation?
I've had many of those.
Do you have any
Yeah, we've just made it, if the custodian, we've had it to where both sides, like dad is out of the picture, mom has custody, and then we've had it swapped. We really only, we have really only involved the custodial parent because they're the ones that have the medical right? If in the divorce or in the custody they say that they have the right for medical, medical decisions, that's who we go to. We will, if we can't get a hold of mom, we can't get a hold of mom. If we can't get a hold of dad, we can't get a hold of dad. We just kind of go forward with that because our focus is not necessarily the parents, it's the kids. And so I've had risk management involved on both of these cases. And we've just handled it that way because our focus is the kid. It's not trying to get one parent to, because they don't, once they get in a room together, you'll see the fighting, and it's not good for the kid. So, and then we've also had it to where mom will say one thing, dad will say another, and so we interview mom separately from dad and try and get those two viewpoints if there's like a big, huge custody battle. We've also had a case where there's a guardian ad litem, and the guardian ad litem is the one, that was the easiest one because if a kid is they're going through any type of custody battle, CPS or DCFS, you should see if they have a guardian ad litem and see if you can get them one, because that was the one person I can say, okay, these are the test dates. Your job now is to get a hold of parents and try and communicate and get them together. And parents would rather work with the guardian ad litem because they know if they fight with him, he can that's going to go to court. Where if they fight with me, they know okay, So that's how I've done things.
Sounds like
Yes,
maybe in
that's
this
great.
case.
Guardian ad litem is a great idea that I hadn't thought of. And yeah, just to clarify, they're right in the thick of a custody battle. So we really had a duty to both parents at that point. and there's a protective order, so we couldn't have both parents in the same building at the same time. But we made it happen. We were able to interview both parents, and it seems to be working out.
And we bought Wes a Kevlar suit, so we're safe for the next time.
Yeah.
I appreciated Wes he went above and beyond to really make this work. We went up that first clinic. My staff was willing to go back up again a couple of weeks later to try to finish this off and, really so we could do, but we were reticent to do that because we were flying on the state plane, so it's really expensive to do that, to not have some sort of an appropriate outcome for the effort expended. So we really appreciated Wes kind of being ingenious with figuring some things out. And I know that once Mom came into the picture, that helped Cynthia to have a much more complete picture of what was really going on with the child's capabilities, the child's daily living activities, so that she could administer a meeting.
One of the things I heard in that's, I think, more broadly applicable than just to when you've got, a separated household, is building those relationship skills to be able to find a way to get or enter the information that's needed. So the fact that Wes had a relationship with the DCFS person, so you never know, right? You never know when you're going to need to kind of reach back a little ways and find someone that you've met with before. So having that positive relationship to build off of, I think, is really important. Of course, being very careful with the protected super important. Great. Well, I'm glad to hear that things are moving in the right direction with that case. It does sound tricky. Anybody else?
All right. We're helping two kids in Blanding who the doctor has hit a lot of walls. They're both like neuropsych kiddos, and the physician there has nowhere to send them. We obviously don't have physicians traveling there that can assist them. And both families are Indian help, so traveling and insurance is an issue. One child is 10 and one child is 7, so ideas. Because we've kind of ran out of them, besides telehealth. I mean, they're in need of counseling, they're in need of some medical intervention. I don't know if you guys know of any physicians that are down that way or closer to Blanding than Salt Lake City. Or any counselors maybe that would do telehealth.
Do they have Medicaid?
Yeah.
So I would contact System of Care and let them know. And let them help figure out, because that's part of what Human Services is charged with. And I do know that they have individuals down within that area. It may not be the total fix, but at least
it'd be something. I mean, they don't have anything right now, and the doctor's really frustrated.
Yeah. So if you can get them involved, that might help you all. Yeah.
They were excited that we were bringing clinics down that neck of the woods, but we don't have a neuropsychologist, and so that kind of didn't really exactly fit the bill. And the fact that we don't have neurology going with us either, like we used to back in the day, so it's kind of a double whammy for these, this poor family.
I'll for sure do that. Any other ideas?
About the tribal health.
They've accessed that. The physician has tried to work through that too. I think the issue is accessibility, like something closer for them traveling. There's just a lack of number of physicians or providers that can assist in this area, and that's close for the families.
Or are they not?
One is, one isn't.
Well, not that it matters, but I wonder if Utah Navajo, something like that, because I'm not sure exactly. Down, so Navajo brings folks down to staff some of those clinics, so maybe it's a possibility.
Doesn't Medicaid help with travel?
Yeah.
They do travel reimbursement. So if you're looking at needing gas money ahead of time, it usually doesn't work that way. You're typically getting submitting for travel mileage post fact, and they'll put it on an EBT card
And
for you after the
it's
fact.
pennies. So families who have a really, really hard time affording
it's not very much.
affording filling their tank up aren't even getting reimbursed for filling their tank up. It's not very much.
I don't recall the current rate, but last year, I mean, it was something ridiculous, like 16 cents a
Yeah.
mile or something like that.
Oh, wow.
So,
That doesn't even get you off the reservation.
So the system of care.
Thank you.
Is there a central number for that? I don't know that we have that. Let's see. That term in the system of care.
Services. Yeah. There's the Optum Healthcare Advocates too. That's their mental health ones. I can't remember the number, but it's on there.
Only Salt Lake.
They might be able to know stuff though.
Yeah,
They're still
they
trying
might
to-
have-
They might have a referral.
Who's the equivalent somewhere else?
Yeah.
Or
I've been in touch with
It's at
Jackie,
least
who's
direct line.
in Roosevelt and Vernal. She's system of care. I've sat in a couple of team meetings with her.
Find people who know some people. That's what it sounds like.
yeah, well, that's why I brought it up because my perspective is I need more.
As well.
Okay.
Afterwards, yeah. Else?
I have a resource. Right Care of Utah is a free speech therapy clinic here in Salt Lake. They usually have a long waiting list for their actual services, but I just got an email from them yesterday that they're doing some free parent workshops for any parents in the community. They're focused on topics that are typical for kids that have speech delays, so things like picky eating. So it's a free class that any parent can go to. So I can forward you that email.
Oh, that'd be great. Can you tell me again what it was called?
Right Care of Utah.
And is it spelled
RITE?
Is that what used
So
to
it's
be
Scottish,
Scottish,
right?
right?
Probably.
Yeah. That's, yeah.
Okay.
Great. Yeah, I love that. Please, thank you. Great. Anybody else?
We have a family right now that has 9 kids, all with like various like medical complications, mental health issues. Mom has stage 4 colon cancer, and so she's basically like totally laid up, can't really get out of bed, do anything. The family is pretty destitute. They don't have a lot of resources. Dad was working full time, but he wasn't overly helpful when he would be at home, and I guess this weekend he decided that he's done. So he has walked away from the family at this point. So we're just trying to figure out what we can do for these kids because they don't have any kind of care in the home. They're not really getting to like doctor's appointments. They're not really getting like anything that they need. The family can't afford hardly to like put meals on the table. Mom can't do anything. They don't think that she probably is really going to be around for much longer. So I don't know. We've contacted DCFS. They've been out there once like a month ago, and I guess didn't really, not a lot happened with that. So if anyone has suggestions.
So there's no income in the household right now then?
No, so mom's not working, and as of now, dad's gone, so they really don't have any income.
So, Mom, I mean, they can apply for benefits through workforce services, and
Right.
they can, and you know, Dad can be involved by force or not, but they can do duty of support against Dad.
Okay.
You know, provided he's working or something.
Right. You might be able to send a caseworker out and tell them.
If the kids are disabled, do they have SSI?
Have they applied for
Have
SSI?
the kids, have someone apply for SSI for the kids? As far as I know, they don't have that yet. Mom's been like on and off Medicaid for her own health needs, but I don't know that the kids really have anything happening right now.
Say that the kids have some.
They do. I know. There's like a 9-month-old who was born really premature and was in the NICU for a long time, and she's living with the great-grandparents. All the other kids are like relatively stable, but I know that they've got a lot of like anxiety.
What's the age range on the kids?
They are 10 and younger.
A lot of young
So
kids.
lots of little kids, yeah. Live in I want to say Kearns. We're out in that area.
Children's Center?
Don't.
See there, the kicker here. Do they have like extended family support at all? Does mom have parents, family? I mean, it sounds like great grandparents are helping with
Great
the
grandparents are helping with the
baby.
baby, and they've said that that's all that they can do. There was a little while where they kind of spread the kids out between family members, and then I guess all the family members were like, "Okay, we're done," and sent them back. So I think that they've kind of exhausted
Are
that.
they part of any
resource.
congregation at all? Any type of
They are. They're LDS, and I guess that has been kind of like
maybe
back and
something's
forth helpful, but
trickling in a little bit.
they are getting a little bit of help from their church.
Kiddos have Medicaid?
As far as I know, they're not insured.
want to send them our way, our integrated services
Yeah.
folks, and we can kind of dig in and see what we can kind of sleuth out and maybe kind of spell stuff out, and we could even help them fill out forms. And
Right, and I think that they just need a lot of extra help because mom is so.
So let me give you the program line for us. So it's 801-273-988, and we'll have some of our staff see if we can help.
Okay.
Tag team if we need to.
Okay.
Cassie, what's your email address?
It's Cassandra, so CASSANDRA C at wasatch.net.
Okay. I'll send you an email.
Okay.
And then we can start.
This isn't really, I don't know if it, but it sounds like what she needs is someone to step in and be this care coordinator for her. Because even when people you're going to give her this information, she's not going to be able to do this. If she's dealing with the kids and cancer and him walking, because it's a process to fill out the forms and submit, and you're denied, so you have to appeal. And someone's got to be there holding her hand, saying, "Look, I'm going to help you with this."
And that's the piece that I think that we can do.
Yeah.
I think we can hop in and kind of say, okay, let's, there's obviously an elephant in the room, so let's bite off, a chunk at a time, but let's work on the basic stuff first, and then we can kind of branch out from there.
Yeah, because I just
I think we could parse it out a little
Yeah,
bit.
if somebody could just kind of partner with her and say, "Look, these are your resources that we found. Here you go." But no, if you can say, "Here's the resources, so we're going to start here," and if you can get her through that, I just think that's the only way that it will happen. Because
The Angel Foundation might go to her.
Wrap around.
They help with that kind of stuff. I just don't know if they go into the homes, but they may.
Depends on what they're tied into. Medicaid going, carve out there, all the rest of it. So some of that wraparound stuff that comes through human services, we'd have to see, what the kids are open for right now. Sleuthing to figure that out. Existing resources, where they're already maybe in the works.
Good. Thank you.
Oh, this is great. Okay, thank you so much. Well, I'm afraid we're going to need to move to our next part of our meeting. But thanks so much, you guys. And know that this group is around too in between meetings as well. So if you need help, we are here to help as well. So I haven't figured out how to do that using constant contact yet, but we'll make sure that there's ways for you to switch your. Okay, Corinne and Tom, you guys want to come up? Sure. And I'll apologize while you're coming up that what we've learned using this room with this computer and GoToMeeting is that we can't put it in presenter mode. So this is what we get. So your notes and the other slides do show, but I think it's a big enough screen that it's probably okay.
We're with the Connector Service program at the primaries. A couple years ago, we tried to launch, going for a little while, but then they stopped it, and now we have just barely started back in August. So I'm Sam, I'm the transitionist on the team.
And I'm Corinne.
their manager. And I hear your case, and I'm like, I could probably really help if we have to have a referral for a specific child. So we'll go through our stuff, but I think you got some help too.
So here's like a picture of the entire team behind the scenes and everybody. So we're a collaborative effort with Primary Children's Hospital, the Intermountain Community Care Team, so the ICCT, the adult teams, and the University School of Medicine and University of Utah. We are a research-based program, so there is a research program. I'll go into that a little bit more into detail. So yeah, basic program information. We assist children with multiple complex so 3 or more complex organ systems. And our goal is to just support the family in any way that we can. Not medically, so we don't actually do the medical hands-on care, but we try to help them get any resources or get them in touch with different care managers. Anything that we can try to do to help the kids grow healthy in their home environment. And so we provide in-home care management, so we go to houses and meet with the families and establish that relationship. And then we just serve a consistent point of contact for the family and for any care managers that are also involved, or anybody that's involved with the care of the patient. And we just continue a formal research study after we set that initial visit. Every 6 months, they send a research questionnaire that they fill out, and it goes. The criteria for our program is children with ages 0 to 17 with 3 or more complex chronic illnesses, cerebral palsy, neurologic impairments, feeding issues, vision, hearing. Some of the ones that we don't focus on just because there is a care management team, or anybody that has active heme onc, cystic fibrosis, spina bifida, transplant, or they're in the neurobehavioral home. And then another criteria is they have to be within the Salt Lake region or South Davis, so it's high up. I think the most is Centerville right now, but if they live outside of the catchment area that we have for now, we are keeping them in mind for when it does become an option. So help to all the patients out there. And so we do also provide care for any insurance provider, Select Health and Select Med. We do run into some issues as far as finding resources, but we'll try to figure all that out. But there's no insurance holding back. Kind of a map of what areas that we serve. So yeah, as far up in North Bountiful, and then we go down to River South. Some of the services that we try to help out with, we do provide evaluation and medical consultation. So with that, we also do try to meet the families if they're having clinic visits, physician visits, primary care. We try to be there, try to help them out. Kareen, our care manager, does travel to the patient homes, also goes to any appointments or anything that they might need help with. And then one thing that we do is we do start to write a shared plan of care. We have a physician and a PA on our team that work at comprehensive care clinic at Primary Children's, and then what they do is they look at everybody that's involved with the patient's plan or patient's care, and then they write the shared plan of care, who's responsible for what when emergency happens or anything goes wrong. Has that and can take it anywhere. So that way, if they go to an ER, they can just go over that and see, all right, it's this issue, who do we need to get in contact with? So we assist with issues, but we don't actually do the teaching for medical equipment or medication. Try to help them out with any resources they may need. And then we just provide referrals to community resources to resolve any social determinants of health. The shared plan of care kind of looks like this, and we just fill it out as we go. With vitals, physical exam, last ED and hospital admission last year, acute issues, escalation plans, and then the care team who's involved. What and what should they be responsible with when crisis happens? So the connector service process. So as of right now, we don't have a referral system inside of iCentral like the adult teams do, but we are working on that. It should be a thing in the future. But as of right now, I know with some of the care managers in the clinics, what you guys have been doing is been sending me emails with patient names, MRNs, and then I search the chart, getting in touch with our team, see if they believe they're a good patient for us, and then we go on from there. But in the when the referral form is put into education thing on that. But then, so yeah, once it goes to once
Can I
the
just say one thing?
yeah,
A lot of you aren't within Intermountain system of iCentra. So if you email Sam, he can email you a form.
yeah. So then I just review the chart, see if I think the patient's a good fit. We talk about it in our IDT meetings, any referrals I bring up with the whole team and see if they why the patient wouldn't be a good fit or why they are. Then we go from there. And once we've set up the initial visit, we start filling in intake forms and different forms just so we can fill out that shared plan of care. Right off the bat, a lot of the families want that shared plan of care filled out just because with complex medical issues, there's a lot of different times where they have to go to the ER or go to the PCH. Want that, who's responsible for what, so I'm quick and efficiently. And yeah, so then we just provide home visits once a week or once every 2 weeks, depending on the try to set up long-term care. Here's our team. Dr. Colleen Marty is a pediatrician that works up in the comprehensive care at Primary Children's, practitioner and nurse practitioner, and then Karina and I.
Which email do we use?
I would use mine.
Yeah,
that'll go directly. That'll be the quickest.
Just read.
Yeah, so it's Salmon, SOMON Ameri AMERI @imail.org.
We'll put it in the. Great, thank you.
Yeah, so Dr. Marty and Christy will meet with patients if they come to the clinic or on the inpatient side. Karine will also meet with patients if they're in the clinic on the inpatient side, but also does home visits. And then I am the one that schedules home visits, and I try to catch them if they're in. Put a face to my name, because a lot of the time that I'm reaching out to them is with text or email. So. Yeah, as I said earlier, so we are a university research study-based program. It is IRB approved, and the University of Utah research team is led by Dr. Howard Kadish. So they're just studying patient-family experiences with the Connector Service, seeing if our program does reduce hospital utilization and same with ER admission or utilization, and just collecting data on demographics, opinions, and social determinants of health. Like I said earlier, after we get them involved, every 6 months there's an assessment that is sent out with enrollment and sent back to the team to gauge that. So yeah, just some key things. This ICCP referral is going, but I think the best way to get in touch with us is to email me personally. And then that main office number is mine, and then if we have iCentra, we do have a pool, and it's called the ICCT Primary Children's Connector Service. And I check that frequently throughout the day. Just there. That's us. Yes.
So when you do a shared, I was involved with Tomoko, with a patient that I think you now have. Do you share that shared plan of care with the primary care provider? And how do we get that?
So once we get it completed, I print out copies to give to the family or to anybody that's within the shared the care team. And I know with the one patient that we've completed so far, we've distributed it between all the care teams, so whoever's
on the plan.
So, but how do you distribute it? Like through email, through fax?
As of right now, I think it might just be through email, but I think they're figuring out a way to upload it to iCentra for that.
We're very, very new. This has only been going for like 6 weeks.
Yes.
So I think as of right now, it's just been emails or in person, just handing it to them. Another thing that we've been doing is printing out copies for the families to distribute.
Yeah, this one family that we have, they're awesome, but the sister's leaving to go get married.
Oh,
yes.
Oh, I need to talk to you.
Yes, yeah.
Like, you're on my list to
They
call
will
today.
not, but they forget everything they come, and so, and then we don't have iCentra, so I mean, I have access to it, but if I don't know it's there,
yeah,
I can't. You know, I don't know to look
Theirs
for
is
it.
not completed
Okay.
yet, and I do need to talk to you,
Yeah,
so
there.
I'll talk to you after.
That's fine.
We'll get one to you.
Okay, and then when they go to so these patients that go, are you involved right at admission with the ED at Primary Children's? Or when they're admitted?
I've been with that patient all day yesterday.
Well, okay, but what I'm saying is so if they get admitted to inpatient.
We get a notice.
Right, and then do you notify any of the providers? My frustration was last time was these kiddos would be admitted, and then we would know until after discharge, and then it was like, oh, we forgot to do this order, and then we can't write the order, and you can't write the order because they're already discharged and we haven't seen them yet.
Okay.
So
we need to. That's a good feedback. We need to work on that. So when people who are in the iCentra system get a notice, but because you're University of Utah, no. So we'll work on that.
Okay.
That's good feedback.
Great, thank you so much, and we'll make sure that you have Corinne and Sam's contact information, so if there are other questions, you can follow up directly with them and also know how to contact them. That's exciting. We're glad that that's moving again, and it sounds like it's really great with the home visits and
it's been good.
enhancements. So thank you for coming and sharing.
Of course.
Okay, so we'll move on to our next portion of the meeting. And so if I can ask our three panelists, Michelle, Jory, and Teresa, to maybe grab your chair or a chair and bring it right up here. Sorry that we're kind of putting you on the spot, but no, this is a friendly crowd. We're very informal here. So it should be great. And you guys, if you want to grab something else to eat, a lot of donuts over there.
On a bread. Eat them there on the bread. Or zucchini.
Great. Well, we're very pleased to have these three folks with us today. So Michelle Carlton, Jory Harris, and Teresa Gawley. And so we've thought for a while now that it would be appropriate and hopefully helpful to talk a little bit more about the role of these particular therapies for children with special health care needs in particular. And so I contacted these folks and gave them a little heads up, I hope, that we would love to hear just a little bit from each of you with regard to your area of focus. In Teresa's case, she has a slightly different role. But what we're really hoping to do in this time and in an interactive way is to better understand kind of what each type of therapist does, generally speaking, and then more specifically around children with special health care needs, recognizing that's a broad area as well, and where the overlap comes. And then also how care coordinators, who is largely this group, and also parents with whom they'll work, can work better with therapists for the best outcomes. So that's kind of, we have a few questions that are from the perspective of either the care coordinator or the parent, because as we know, parents are care coordinators. So we'll get to those in just a minute. But what we'd love is if you wouldn't mind just taking a couple of minutes and we'll go down the line and just tell us a bit about yourself and then kind of what you do in that role.
My name is Jory Harris and I'm a speech language pathologist. And I work as far as speech therapy goes, some of the roles can overlap, I think, sometimes with OT and PT for disclosure, but overall, as far as a speech therapist, we have many hats, and a lot of times we can do feeding and evaluation and assessment. So after the children leave the hospital, sometimes working with, they can work on evaluation, treatment, child. We can also do speech evaluation and treatment. So speech being different than language, and that speech works more in the production, saying your sounds correctly, and language being sentences together. And then, but on a broader term, that's general, but we can get kids, help them with assisted communication devices, so children that are nonverbal. We can work with the family to identify alternative means of communication, whether that's sign language, whether that's any kind of outpatient device, getting them information on that. We also would do can do more cognitive testing in conjunction with psychology to determine what they're capable of doing. And I'm sure I'll think of a bazillion things later, but
That's okay.
okay.
Perfect, thank you.
My name is Michelle. I'm an occupational therapist. I work for Primary Children's. I think the best way to think about occupational therapy in general is to think about our daily occupations. For adults, the things that we do that occupy our time are more like jobs, self-care, or family. When we think about children, especially the clients that we see at primaries, we're looking at play. We're looking at kind of helping facilitate some of their school activities. There are school OTs, so we're not making school collaborate with the schools. We're working on helping them do those things to take care of their bodies, like working on dressing themselves, working on meal times. Toileting is a fun one. And I think the biggest one, I might have mentioned it, is just play. So being able to play and learn and develop life skills through those leisure activities. I think OT can get a little confusing in terms of overlapping with PT or speech. The way that I make sense of it is that it always goes back to a functional activity. So PT might be working on a gross motor movement in order to walk or ambulate or functional movement. I might be working on functional movements in order to put on a shirt or in order to reach for a toy so that I can feel more functionally. I know speech and OT can get compared a little bit. We will do things like visual schedules and incorporate some first ends that we learned from the speechies, but we're mostly using them to help kids do their morning routines or nighttime routines or break down the steps of putting on a shirt. Yeah. Oh, and we can also do like splints and casting, feeding. Yeah, I don't do feeding, but there are a lot of OTs that do. Yeah.
And then I'm Teresa Belli, so I oversee rehab at Shriners Hospital. And so in our therapy services, we have OT, PT, speech, and rec therapy. And then we also have a motion analysis lab where our researcher and our physical therapist will look at the actual movement walking patterns of kids on a video system that they have set up. And then we also have a seating department for wheelchairs. I'm an OT by trade.
Teresa, would you be able to tell us just a little bit more about PT as you know it at Shriners, both kind of generally and specifically for complex needs?
Yes. So our physical therapist and the same at Primary Children's. And do you guys have a PT at UDAC? So the PTs are going to look at more of the functional movement. How are they doing with walking, riding bikes, and things sort of that nature. At Shriners specifically, our PTs also do a lot of the equipment evaluation. So they'll look at standers, walkers for kids, and then wheelchairs. Specifics that you guys want?
Probably get. That's great.
I think most people know what PT more than OT or speech.
So, yeah. Great. And guys, if you have questions, you can interject. Terrific. Okay. So we sent you some of these questions. Hopefully this won't take you by surprise. And so these are as much for our folks in the room. But so from the perspective, again, of a care coordinator or perhaps a parent, the question would be recognizing the caveats of insurance coverage limitations and availability, and working with a group of therapists, so within a clinic, within Shriners, within Primary Children's, or within that, how do I, as the care coordinator or parent, best match between my child or patient and the therapists, all those caveats around insurance. So granted, your insurance might not be your exact focus, but I'm sure that comes into play with the patients. So that's, I think, a big question for this group. So
I think for Shriners Hospital, we will see any kid regardless of their ability to pay. We work with most insurances, and And in terms of getting the right fit with the therapist, that's really hard, I think, on your end to try to facilitate. But I know on our end, as therapists, we always try to open up the door that the kind of that relationship or the rapport between the child and the therapist isn't what is the best match, that it's an open door to see a different therapist. We all recognize that we're not going to be the best match for a child. And so hopefully the family feels that they can ask for a different therapist. At Shriners, we have 3 occupational therapists. We have several physical therapists. We do have a speech therapist. So if it's not working there, it's a conversation. Most of us as therapists are pretty good at adapting. But if we don't know that there's an issue, we can't do that. That kind of answers that question.
It definitely does. I'm not sure that parents always feel empowered to verbalize that, whether it's to the therapists or the clinic itself or to their coordinator or primary care team. So knowing that we can encourage that is very helpful.
And I think on your guys' end, that therapeutic relationship families about what a therapeutic relationship is, and if it's not working, even if they haven't spoken up to you, but just say, if it's not working, know that any of us would make change. See a different therapist.
At primaries, we follow a very similar open relationship with families. I think we also have the benefit of having 5 different outpatient sites. So not only sometimes might it not be a great fit between a family and a therapist, but just traveling to a particular location might be challenging. We have sites in Riverton, Taylorsville, Downtosh, Layton, and Bountiful. So sometimes even the site itself isn't a great fit. So there's OTs, PTs, speech therapists at every site. So families always have the choice. In terms of insurance, every therapist that starts follows the same credentialing process. So there wouldn't be one therapist that would be able to see a child over another unless they haven't been credentialed yet through Medicaid or Blue Cross, which sometimes takes a little bit longer.
At UDAC, it's a little bit different because we just do assessments. But we make sure part of the assessment, it's an interdisciplinary assessment. So when the kids come, they see OT, PT, speech, psychology, developmental pediatrician, whoever they need to see. But from a therapy perspective, we make it a very important part of our assessment and after visit summaries or visits to communicate with the family what their rights are and looking at their resources, looking at their insurance coverage, giving them the support they need to go and get the services that we've recommended. We also utilize Utah Family Voices a lot. We have someone there on site probably 90% of the time, so they have that ability to meet with Utah Family Voices and to learn from them firsthand what additional things they can provide support, and we often use integrated services as well for those families that might need support.
Are you finding that most insurances cover these services like fairly well? I mean,
the only challenge we've had is we don't get, and I don't remember which one it is. Select Health, when kids are coming for evaluations, Select Health prefers their psychologist for diagnosing autism.
About for OT?
For OT, I haven't seen too many issues with covering evaluations. Every insurance covers different things. So private insurances may cover some codes over others, and that can be tricky in terms of what I'm working on. And obviously we're billing for what we're working on, but that can make it more tricky for families depending on what their goals are. In terms of Medicaid, I know that they cover, depending on a set number of visits per year. So once you hit that cap, there is an appeals process that the family can go through, and I've had some families go through it and have success, and we get a few more visits. Some families that go through it, and we have to wait till the next year. At primaries, one of the things that we do, and I think it helps with this, is our model of care is focused on home programming and doing episodes of care. So we're not going to see a family 2 times a week ongoing. We would set up an episode where we're seeing them maybe 10 times, and families are involved, and we're really focused on building a home program so that they can be working on these things at home. So I think for those kids that maybe only get 10 visits a year, it still works really well with our philosophy.
It's the same at Shriners. Similar. Oftentimes, we don't know if a service isn't getting covered. So we'll put in the coding and the billing, but it happens on a like from billing side. That's where they get the what isn't covered, but we're not getting that as therapists. We're not getting that. So again, the more that families can reach out to us and kind of have that, the better. Because I think as we are all aware, the medical field is so we don't know what's happening on one end. So I think that's kind of been a little bit of a frustration. And also on the family end. But generally, again, at Shriners Hospital, we work really well with families. That's an ongoing conversation with our financial. So you would, if you know that a particular billing code isn't going to get covered, you would work to be able to continue that kind of therapy, but have it paid if it's necessary. Yeah, so we will still bill the code. Right. And that's, I think, understood in the. So we can't change the code. So if we're working on a particular type of therapy, we have to bill that. But we will work with families on different options to pay if their insurance won't cover that code. Similar.
Yeah, Primaries I know offers like a pre-service discount. So if insurance doesn't cover it, 40% off if you pay the day of. The front desk works really well with the families on their first visit at the eval by presenting them with insurance facts and information, and they even give out a list of codes that we may bill for, so families can feel empowered to call their insurance company and ask specifically about those codes that we may bill, versus just asking general questions.
I think that's a really nice option. I know that just in my household, I mean, my wife and I are both well educated, and if you think I can figure out my insurance policy, you got another thought coming. Hundreds of pages of legalese that's really tough to figure out. So I think it's really nice if you can specifically call and say, these are the codes that might be billed out, and what are our chances of getting paid. It's sad to say, quite frequently, your ability to get services for your child, although you want those services, is going to really hinge on your ability to pay for it. Because, it's awesome to get the service, but then when you're saddled with a monster bill after the fact, then it's deflating. So I think that's really nice to be able to educate families. Goes to you.
I think one of the hard things too, Jory, I don't know if your experience in speech therapy, but a lot of insurances will cover rehabilitative care and not habilitative. So for kids that developmentally haven't developed speech, it's often not covered because of that one word.
So I'll often code it as a disorder versus a delay. We're just giving diagnosis. So, we're evaluating. So that's it's a little bit easier to get away. Fortunately. But I know in my history of they're going to catch up. So it's always making sure you use those right words, the wording. And I've always historically told parents, and I've been out of that, but I've always historically told parents is, before you do any evaluation or before you do any treatment, is just call and say, what kind of speech therapy do you treat? And what are those codes you use, or what does it need to say, or to get, encourage them to get the verbiage that they
I think we have to take on a lot as therapists in terms of when I'm writing up the evaluation, but also writing up the goals. So if I'm writing up goals and working with a family, I want to make sure that my goals can be met and are reasonable. Otherwise, I know that can be a flag for insurance to stop covering. we are rating our evaluations and our reports that we're seeing progress or that we're making changes to.
Two things really quick. One is I think our GoToMeeting people are having a little trouble hearing, so there's not a ton that we can do, but maybe just talk a little louder. This is the mic right there. You'd like to think it's capturing things perfectly, but it sounds like we could talk a little louder. So the second thing is I'm really hearing that if we can empower families to understand, it's terrible, right? You're therapists, but you've got to find a way for families to know the questions to ask before the therapy even begins. That's really tough. So that's exactly, I think, the kind of information that we want to provide to this group for them to provide to the families. So almost sounds like we need a little script. So maybe we can work on that and send something out that, this kind of language is helpful when you're talking with therapists at the very beginning. That's it. So I don't know how they talk with you, right?
They'll talk with usually whoever's scheduling the visit. They'll talk with the schedulers.
And are those people in the know about a lot of this stuff?
Yes, but insurance is constantly changing. And so we're in the know as much as we've figured it out with different insurances, and it hasn't changed on us.
Yeah.
That's the same. The front desk is the one that calls and helps the families to schedule, and they will let the families know that they're responsible for anything that they already know about that particular insurance. But we do try to kind of leave it up to families so that they don't end up with a bill that they might.
For you with Intermountain, the Intermountain Financial Assistance, they do help with PT and OT and speech and all that. So the kids that you try to apply to get the additional services and they don't qualify, when you apply for that, it's for 6 months forward as well. So they'll help with past bills for the entire family and the 6 months forward. So you could use that for them. And it's case by case, so it's not based off income or insurance or deductibles. It's just case by case.
Okay. The example that you gave of disordered speech versus delayed speech, is that an issue for reimbursement coming from us as the referring provider with the associated diagnosis attached, or is it the issue that of the diagnosis that you attach as the evaluating speech therapist? Does that make sense? Like, am I messing it up for them if I put delayed speech versus disordered speech on the referral?
Yeah. Oh, so when you refer, so if you're going to refer to our clinic for consultation,
Right, like to start your services kind of thing for eval and treat.
I don't think so, because
It's more about what you document.
We do the evaluation and then how we
Okay.
what coding we use.
And I think what you guys need to know as well is we're not coders, but we're expected to code. So, and with the new ICD-10 that came out a little while ago, and just with the language that is used, it's hard even for us to keep up with the language, the code, and then which insurances want what language. It's really hard. So if a family gets a denial, that's a great time to kind of open up the door to appeal it, and to ask for a peer review from the insurance, where they'll talk to the therapist, talk about what they're seeing and what the evaluation actually showed.
So on the medical home portal, we have some appeals information. Maybe structure a template or something on there that might incorporate. Certainly not assuming or jumping to the conclusion that that happens. So some information there. Okay. Good. Okay. So let's go to our next question. And you guys already sort of touched on this, so this is great. How can I work with a therapist to set and meet reasonable and achievable goals? That's the first part of it, and then the second part is what if they aren't met?
So I think I'll speak from the PT side, because you can do speech, but from the physical therapy side, oftentimes a family will come in and say, I want my child to walk. They're not even crawling yet or pulling to stand, or doing any of the kind of precursors and foundational skills that child will need to walk. And so hopefully the therapist works with the family to say, that's a great long-term goal, but we need to kind of work on the short-term goals that maybe we try to get families to look 3 months in advance and recognize we're not going to get this child walking in 3 months, but what can we do to kind of build a foundation to get there? And so hopefully the therapist is working with the family on what is achievable after they've done the evaluation and know a little bit about what they can achieve. If the goals are not met, hopefully there's been progress made, and Michelle kind of spoke to this, because if the therapist is able to show that progress has been made, then you can appeal more visits and just say this child's just taking longer than expected. And usually insurance companies will entertain that appeal.
Yeah, I think tying off of that, I think the biggest thing for us is just making sure that we're looking for that progress and we're constantly collaborating with the family. I know I mentioned that we do those episodes of care. So we do have families at every single one of our visits. We're always collaborating on what's going well, where are we in terms of our goals within that episode. So luckily for us, those episodes, we're able to set goals that are going to be 3 months from now. So when we're working to set those goals with the family, it's easier, more short term, and break it down. And again, I think a lot of it comes down to just the plan of care. So if I'm starting and we're seeing the child every other week and we're not seeing progress every other week, that kind of leads into conversations with the family of maybe changing. If I drop down to once a month and we're keeping working on things at home, I'll be able to see that progress and continue to justify services. But a lot of it, I think, just comes down to collaborating with the family, again, setting realistic goals, maybe that they're not walking, but that they will be able to maintain. Or maybe they're not feeding themselves, but they'll be able to scoop food, maybe not bring it to their mouth. Speech, I don't know.
So I'm curious, Michelle, so the episodes of care, is that like one visit? Tell us a little bit more about that term and what it really means for that primary.
So what we think about as an episode, it's just a period of time where we have visits that are working towards set goals. So when a family comes in, a lot of it depends on what their concerns are. Sometimes they have concerns that we might be able to manage in 4 visits. So our episode would be 4 visits. Sometimes it's a little bit more, and so it would be maybe 8 to 12. But what that episode is it's just an opportunity to get some tools to work on a couple of concrete goals. And then what we do is we take a break. We want families to feel like they can work on things at home. We don't want children to feel burnout by coming to therapy multiple times a week for speech, PT, and OT. That's no fun. And then depending on how that break goes, families are always welcome to come back. So we'd be able to modify goals if there's something new that comes up, or if they hit a plateau, being able to maybe modify our approach a little bit. It's a good opportunity to see how the child's progressing in their home environment and in the community.
How compliant are you finding the parents are in doing that home programming? The reason I'm asking is several years ago I taught piano lessons for a while, and I could tell when the kid hadn't practiced all week. I'm just saying, it was it was like not good to take mom's and dad's money when kids not practicing all week. So I was just wondering how compliant you find folks are with doing that home program.
I think a lot of it comes down to how you approach that relationship with the family. I think if you give them clear, concrete things to do at home, I tend to think of myself more as a coach than a therapist. I want families to show me that they can do it before they go home. When they come back, I want to see them working with their child on what they've been working on. I want to hear what their progress is, what their concerns are. I think that's how we better resolve that. There are a lot of families that have a hard time, whether it's mom works 2 jobs, dad works 3 jobs, and it's just hard to do the home program. Whether it's just not a great time in life. There's a lot that can lead into that, but I think just being able to work with the family and hear them out, and maybe that comes down to changing the plan. Maybe coming once a week is too much, and that's just not enough time to work on things at home.
Maybe scaling back or...
And I think what's good for you guys to know as well is we will often in therapy discharge a child or discontinue their services because they're not working on the home program, and we're not going to meet their goals.
And so if we've worked with the family and they're consistently coming back and not showing progress, then we might say, now's not a good time for therapy. Let's take a break, or let's, revisit in 6 months after this has kind of settled down at home. So you guys might get feedback back to you saying, well, they said I didn't need therapy. And that's not the case. They need therapy. The family's just not kind of meeting their end of the bargain.
This is Natalie. I'm a nurse practitioner with Integrated Services. Can I just make a comment? So what I feel sometimes with families who aren't following through with like physical therapy or whatever is that if you can really help these families who are completely overwhelmed, embed the physical therapy or activities into their daily routines. It seems less overwhelming to them. They don't have to take out time to do physical therapy if we help them embed some of these activities to help their children right in a daily routine. Because I know they're so overwhelmed, and to think that they have to do physical therapy sometimes is more than they can do. Anyway, sorry, just my comment.
Yeah, no, I appreciate that. And I think different therapists approach it differently. I have 4 kids, and so I recognize that issue. And so I, as a therapist, I try to do that, but I think different therapists, especially newer therapists that have come out, don't always think that way. So it's also nice if you guys can share that with families, maybe ask your therapist, how can I just make this part of our daily life routines? For OT, I always try to make it part of when you're eating breakfast, then do this. Yeah.
Because it is your routine. Well, and even with communication and speech and language, and as we send them on our way, we want to make sure, because we often get parents that come in and say, I want my child to talk. And you're like, okay. And so we kind of have a mutual understanding of what that means. And we make a point of sharing with the families that this is the long-term goal, but in the short term, communication means a lot more. It means pointing, it means looking at someone, it means gesturing. And we, at that time of the evaluation, or just following it, is we give them things to incorporate throughout their day to support communication, because it's amazing, and usually I think all our parents do a good job of again showing us what they're doing. Show them a couple things before they leave to send them on their way to support communication at home. So we're giving them the tools to get, and they practice, they show us in front of us, they take it with them, as they're getting started in treatment. And there is a lot of resources. There's a lot of online resources as well as books that we'll share with the family, that things are incorporated in everyday routines right now, specifically for that. So we'll include a lot of those in our evaluation summaries. So.
How do you guys sort of handle, or does insurance cut them off for no-shows?
So at Shriners, we're trying to implement a no-show policy because we have been hit a lot with that.
Yeah, I see that a lot.
But again, it depends on each family situation. So after about 2 no-shows, then we take them off the schedule. But that doesn't mean that they can't be seen for therapy again. Oftentimes we don't know why they've no-showed. And so if there's been kind of a situation or things like that, we'll work with families. Or if we just have families that just cannot seem to follow routine visits, then we'll work with how they schedule those visits to help them. Try to, obviously, I think that we all deal with no-shows and cancellations and trying to minimize the impact on other kids' therapy.
A lot of times with insurance, it's based on compliancy. So over a long period of time, if they're not showing compliancy, that's when the insurance companies say,
I've never had an insurance company deny for no shows. I've had them deny for not making progress.
Showing compliancy, they will.
I think at primaries we follow a similar policy. If a family cancels a lot of visits last minute or no shows, we always follow up with a phone call and try to get a hold of them so that we can process kind of what happened and work with the family to maybe it's a different time of day they need, or maybe it's just much right now. At primaries, we let families schedule 4 visits at a time. That's because I think the demand for therapy is a lot higher than what can be offered. Sometimes it's hard to get in at the frequency that we want, so being able to schedule those 4 visits is nice. If we have a hard time with attendance, it may suggest scheduling the week of or scheduling one at a time. But again, that comes with the family collaboration.
We're pretty flexible too. I think as providers, we want to work with the family. After 3 no-shows or no communication, we're going to reach out to them.
I had a question about goals for families. So how do you kind of keep families motivated and not getting discouraged when they have a goal for their child to walk, but they haven't, they've got a long ways to get there? So how do you keep that discouragement from setting in for families who have attainable goals that are pretty lofty?
I think we try to break things down and talk about the little moments and celebrate the little successes and trying to tie that back to the goal of walking. For a child, it's like, great, they've maintained standing and they've done it for 5 minutes, and then the next time you see it, it's 10 minutes, and just trying to show them that what they're working on is making progress, that their child's getting stronger. And so we try to celebrate the little moments. Again, by breaking that big lofty goal into what are the foundational skills to get to it, helps families to understand, oh, my kid has to be able to have the strength to stand for this long before we can ever. So taking away the goal of walking is kind of how we deal with it and go back to the goal of the foundational goal.
It's very similar for OT. Again, it's going back to the goal that we set and every time kind of celebrating the successes. I think talking with families at the start of your visit and talking about what's been going well at home can sometimes help kind of prime them for feeling good about that visit. Sometimes we'll bring back activities that maybe I haven't done in a few visits, and every time the child does it for 5 more seconds or 10 more seconds or has more control with the spoon, just really highlighting those little progress marks can help families feel those successes more than focusing on that they're still not doing X, Y, or Z.
It's the same for speech too. Goal of communication.
So we have about 6 more minutes, I'd say. So here's our last question. So help me understand how insurance generally pays for therapy and how that affects how we, whether it's the primary care office or the parent, work with therapists. So we've probably done a fair job at covering this. And so I have actually a different question. And it's along the lines of some of these others that we've heard. And that's about how the medical home team, how the primary care team, coordinators can understand these goals so that they can talk with the families when they see them in, whether it's a regular visit or a visit, to just check in and say, how are things going? Is there a way, it's this idea of the shared plan of care. How do we communicate with each other? How is it possible for a primary care team to get a copy of those goals? Certainly they could get it from the family, and they're often overwhelmed. So,
if you have a one-on-one, if you have a face-to-face contact, asking the family, "Oh, can you show me what you're working on in speech?" and just coming out and asking, how do you feel the progress is going, and just share the goals.
At primary, one of the first questions we ask at evals is, who was your referral for us? And after the evaluation, most therapists make an effort to either call that physician or a nurse primary care doctor, or send them a message log if they're in Centra. If not, we try to reach out by phone. We always have the option of sending reports, so if anyone's ever interested in getting one, send them to you, or families can send them to you. I know that if you're a physician, we can send it without the family having to sign a form. But if you're like a school, if you work for a school or someone that's not kind of connected or authorized for us to send to. As long as the family fills out a release form, we can send you copies of so if there's anything or requesting, just let us know.
And on the other side too, care coordinators could do that too. Like if they're like, oh, I'd love to see what you're doing, have a release that you could share with, if you wanted copies of the evaluation results.
And then at Shriners, we're a little bit more unique in that our plan of care has to be signed off by a physician. And so the referring physician is usually within the Shriners system. And so that physician is looped in to the plan of care and the goals already. But then outside of the Shriners system, you would have to request to get that. This was great. Do you guys have any other questions? We're almost out of time.
So for Shriners, do they have to be hooked in with one of your physicians? Like if we send it from one of our physicians strictly for speech, OT, or PT, would they need to see one of your physicians in-house to have those services first? Okay.
So, and even maybe you can speak a little bit.
Yes, they do need to run through the outpatient clinic, even if it's just a very at that time, when they have that first initial visit, families can opt in. We have a new health information exchange, similar to what they have at Primaries. We've just launched it, actually. But families can opt in to have their primary care physician receive all reports. That outpatient visit plus any therapy appointments.
And then with Shriners, you have to have an orthopedic issue. So we're a specialty hospital, and it does really need to have some sort of orthopedic. So I brought some handouts to help with that, like a lot of just foot and knee issues that parents have questions about. I have handouts on that. With the exception of the orthopedic issue or going through our outpatient clinics, is our motion analysis lab. You can sometimes, they'll still have to go through and get an order from one of our outpatient clinic, but you can, I brought a referral form for sending them to the motion analysis. And that would be for kids that need to, they're usually being looked at, and they usually have orthopedic issues. They're being looked at, are we doing surgery or not? And they're doing the full video analysis of the gait pattern. And so I brought information on what that is. So there's that with the referral. And then just some, will they grow out of it? Feed and stuff.
Thank you. This was really helpful. Thank you so much for sharing your time with us this morning. We really appreciate it. All right. So I have the deep side because I just took my daughter to a well child checkup, and it was great. We had no waiting. It still took an hour and 10 minutes, and I have such respect for what you guys do because they're intense, right? And she is typical. The things that you have to keep track of for these families, it's just kind of mind-boggling. And now we're saying, you've got to talk with families about their goals and forms and all of that. So thank you so much for what you do for these families. I think it's just remarkable. So, and it's great to understand better how kids can benefit from these rehab services, these therapies. It's just tremendous. Our next meeting is on October 17th, and it's our typical October meeting, and that we'll have the UCA Asthma Program folks come and talk with us, and so we're looking forward to that, along with Gabby and her asthma activities as well. And then some of you were willing to give us a little bit more of your time today, and so we will be having a focus group with those folks in room 155. That's just down this hall, the first floor on the right, I think. So thank you, everyone, very much. I think there's more food. Please help yourself on your way out. Have a great rest of your day and week. And we look forward to seeing you in October.
I'm not around here.
And then I drive to the gym.
But they might have after it, but I mean, they got him, showed him on a TV. Yes. Money.
And enjoying your son's photos. I hope there's something in there.
Your meeting has ended.